indeed, Marianne. And we'll come to, this is your advance warning that I will give you, open up to the floor for some questions in a few moments. But I'm going to abuse my privileged access to the microphone to ask a question first. Because, so you and I have a shared interest in innovation. It's one of my particular topics. And I've always been very struck by the agricultural field in the United States, because this is actually where the diffusion of innovations model started, because between the universities researching new varieties of corn and new agricultural practices, and between the farmers who are actually doing this on a daily basis, they have this entire structure, the Agricultural Extension Service, which is a whole body of people who are there to act as a bridge and a support system and as a communication structure, to be this bridge between the invention and what happens in practice. And it always frustrates me whenever I see this, because I think, well, why don't we have something like that? And the industry, of course, does do this very well in reaching out. But from the perspective, from a management perspective, what kind of structures do you think we would need to actually teach the dog not to sit down and to actually put in place these kind of innovations, do you think?
I do think that we need to organize by country and across countries arenas for discussion and learning and dissemination. And one of the problems is that healthcare managers, unlike clinicians, are almost not allowed to go out of the country to come to conferences like this. You very rarely see healthcare managers on conferences abroad. You rarely even see them in country. Uh-huh. They are really hard pressed for time. They don't have any budgets, and it's not an accepted part of their everyday situation that they need constant learning. And at the same time, they are the object of all these forces who wants them to do lots of new things, to implement, as it's called, changes. And there are directives, and there are the professions pressing on for new methods, etc., etc., etc. And looking at it from a healthcare manager's point of view, it's like a cascade of things. And sometimes the results, as we can see in Europe, is that nothing is done. So the good things drown in the cascade of too many things being asked to happen at the same time.
Yes, I was very struck by Gary's point in the previous session about actually what we could do with is a bit of stability, not reforming for a while, so we slow down that cascade a bit. Let me open the question to the floor. We're going to have to finish sharp at 4 o'clock, as I said, but we have some time before that because my speakers have been extremely disciplined about sticking to their time, for which I very much appreciate. Are there any questions that people would like to address? Yes, please.
Thank you. Tessa Richards of BMJ. Talking of new innovations and technologies, do you think there should be greater use of this coverage with evidence development? One very notable example recently, well, two notable examples, which is the use of the transcatheter aortic valve implantation and metal-on-metal hips. Technologies which were introduced rapidly, diffused rapidly, and then only later on the dangers and problems with them come to light. And if you restrict the number of providers who can use the new technologies and accrue evidence on benefit and harms, it might be a better way to introduce the technologies. Can I have your views on that?
May I start?
I think we're going to get a range of answers to this one, so you start.
I'm so happy that you introduced those two examples, because coming from Sweden myself, we have since many years developed quality registries. So both of those two innovations were stopped much more quickly in Sweden than in the rest of Europe. And these have been built by the professions, by the doctors, to give them a tool to look at the outcome measures and doing it in real time. And I think one of the things that we would need on a European level is to develop those kind of quality registries, because you cannot, in a complex system, always do what you asked to see the real effect before it's being tested on a large scale. So I think we do need to accept the fact that we can't know everything before we introduce new stuff, but we need systems like the quality registries of Sweden to be able to monitor very effectively when things are introduced on a large scale.
Nicole, you specifically, may I come to Nicole first, because you specifically, I'm going to challenge you particularly on this, because I noticed in your slides one of your challenges was good technologies are not being diffused rapidly enough, or not being used enough. But the message here was, well, actually maybe we think that they're good technologies and only later do we find out that they're not. So what's your perspective on how we strike that balance?
Yeah, in fact, the problem is that we have completely different technologies. The metal issue, and maybe, you have always the question about how much time, how many years you need to do studies, and how do you use all those data to improve. Let's say when you look at the pharmaceutical industry, for example, you have different phases of clinical trials. It takes ages, and even if it takes ages, when and you have maybe 1,000 patients having gone through, still you continue to learn other side effects and things like this. So you never know until you go to the big scale. You don't have this possibility. But on the other hand, you have innovations that, for example, people are not even aware of, like, telehealth or dermatology or teleradiology or telemonitoring. Those technologies are not finding a space just because of the way healthcare system is organized.
So what's the answer to this question about how should we respond? Would you be in favor of narrowing it down to a subset of hospitals initially, or do you think the quality
In
registry
fact, I like very much. I think that we are sitting in golden data. Patient registries, all these clinical data. The problem is that all these data are kept in silos and not even collected together. We don't see if we could learn a lot on trends, etc., that would help in going through continuous improvement. But I believe European Commission has launched a European project called Parent, which is how to best use patient registries to the benefit of the patient.
Okay, thank you very much. Rolf, please.
I'll join Marianne with delight. So no different answer. But what I wonder is there are so many examples where things were taken off the market in America, in Australia, many, many years before Europe. And that must have a reason.
Yeah. Well, and I think that if we had longer, and I'm going to put an answer to this question myself as well, I think if we had longer, we would get into a discussion about the point that Nicole raised, which is about data protection. Because data protection law, people have become very concerned about, we've all been reading about spying allegations, and anybody who isn't having their mobile communications intercepted at this point should be embarrassed, I think, because you're clearly not very important if nobody is listening to what you're saying these days. But because of that, we're trying to put all sorts of legal restrictions on the sharing of data in place, when actually that is blocking to an extent the kind of sharing of data that would allow catching of these kinds of problems in practice. So we have some careful balances to strike here, I think. Colleagues, I'm sure that there are more people who would like to intervene. There are more people who would like to ask questions, but I'm conscious that we must finish on time in this session, and it is 2 minutes to 4. So I thank let me thank my speakers once again, Rolf, Nicole and Marianne, for their excellent contributions. May I thank also our hosts in Lithuania for the opportunity to put together this session, which I thought was very useful. And please join me in thanking again the contributions that they made.